Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research. And we're here to explore a wide range of topics with you through interviews with content experts.
Hello, AOMP podcast listeners. I am Nick Rainey. If you're a longtime listener, you might remember listening to an interview or two that I've done either as an interviewee or as an interviewer. This is part of our desire to make sure that we are utilizing pelvic health research along with orthopedic research and combining them for this AOMP podcast. We've been working on this for about a year and a half, and so you may remember some of our other interviews. Dr. Kelly Wilson and I were the first two when Dr. Schaefer interviewed us end of December, and we're keeping this going. And I'm joined today by Dr. Jasmine Green and Dr. Minija Edgar. How are you doing today, Dr. Green?
Good. Thank you for having me.
It is definitely my pleasure, and hopefully everybody here appreciates it. How about you, Dr. Minija Edgar? How are you?
I'm doing so well. Thanks so much for having us. I'm excited to chat about all things ortho and pelvic health.
Well, very good. That makes three of us. I'll introduce Dr. Green first, and then Dr. Edgar. Dr. Green is our orthopedic sports physical therapist, and which is important that I define that for the case that we're going to be doing. She did sports residency at Body Central in Tucson, Arizona. Coincidentally, I'm just over an hour from where she did her residency. I'm in Sierra Vista, Arizona. And let me finish with Dr. Green. She is also the sports fellow at the University of Arizona, which is also in Tucson, Arizona. And so she gets to combine with outpatient there at a clinic and then also at the University of Arizona. And the Dr. Edgar, she did a pelvic health residency at Body Central there in Tucson as well. And her professional passions are the role of physical therapy and sexual medicine, postpartum recovery, and breast cancer treatment recovery. And she teaches yoga on the weekends. Is there anything either of you would like to add to that?
Nope, sounds good.
Just a second, I need to pause this. For this case, it was a combined orthopedic and pelvic health approach that was presented in a poster presentation at CSM 2024. The title of it is Management of Sacroilliac Joint Pain with Combined Orthopedic and Pelvic Health Rehabilitation, a case study. As I was reading through here, before we get to the details of the case, I wanted to highlight that it said that the patient would have a pre-established plan of care once a week with orthopedics and once a week with a pelvic health therapist. Can you elaborate on how that pre-established plan of care was initiated?
Yeah, I can speak on that. So our patient for this case study was actually a part of a larger research study that Minnie and I were doing. And so our larger case study included multiple females that we were looking at the same thing. And so the research study, our plan of care, we had already drawn out that it would be 2 times a week for 8 weeks. And based off which group you were randomly assigned to. So there was a orthopedic only treatment group, which just saw me. And then there was the combined treatment group, which saw Minija and me. And so if you were in the orthopedic only group, you saw me 2 times a week for that 8 weeks. And then if you were in the combined treatment group, you were the 1 time a week with Minija, 1 time a week with me. And so because we had some poor compliancy with the entire group of the research study, and our case study patient was the only one that completed the full plan of care for CSM, we just submitted the case study.
That is great info. Thank you for elaborating on that. It also highlights the challenge of doing research in standard clinical settings. It is as I've worked on it myself with some other things, I've seen the challenge of that firsthand. Thank you very much for that, Dr. Green. Dr. Edgar, are you able to collaborate with the primary orthopedic physical therapist frequently in your practice there?
Yes, if we are seeing patients who we believe would benefit from a combined approach or even just another set of eyes to look at things, it's pretty easy to reach out to our colleagues just on site. When Jasmine and I were on site together at the same clinic, there were several occasions where she would send me a female athlete who was screening positive for pelvic floor dysfunction. I would take a look, do an exam, and offer the patient some guidance on a few things that might be able to help them improve their athletic recovery when it came to their pelvic floor. And that goes for not just, Jasmine and I, despite our great rapport, we're not the only ones with this great idea. So the other clinicians that we are working alongside also have the ability to collaborate, which I think is an excellent resource and improves our patient outcomes.
Well, I would definitely agree with that. That sounds excellent. All right, we'll get to the details of the case now. This case was a 24-year-old woman with bilateral sacroiliac joint pain. Dr. Green, we'll start with you. Say, correct me if I'm wrong. I think that you saw the patient first. Is that correct?
Yes, that's right.
So, as the orthopedic physical therapist, can you tell me about the testing that you did and how that indicated to you that this was an SI joint problem?
Yeah, so I can expand on that a little bit. I think SI joint pain is kind of funny because we have that Laslets cluster of testing, but I think in like a practical clinical setting, most people either aren't using that or it's just like a very irritating test, but they're not very specific, but it's the best that we've got, so we use that. So I basically, for research purposes, used the Laslets provocation test. I used those 6, and then I also ruled out any associated hip problems that they had going on, specifically for this patient that we're talking about in the case study. I ruled out other associated diagnoses in the hip, and then she also had some associated low back pain. But to assess, actually to confirm that she had SI joint pain for this study specifically, we used the Laslets cluster.
That's an excellent answer. And now I'll turn it over to Dr. Edgar, the pelvic health physical therapist. Can you tell me about your examination process and how it was or was not informed by Dr. Green's examination?
So I performed a standard pelvic floor evaluation, similar to one that I would do if I was meeting a patient for the first time and I wasn't collaborating with Jasmine. I didn't read Jasmine's documentation or talk to her much about the patient's ortho exam prior to my exam. I didn't want her findings to hinder my ability to objectively assess the patient. So I went through my standard questioning in terms of urinary and bowel dysfunction, sexual function, all of that, and then went on to do an internal pelvic floor assessment. And I think that was the best approach. I didn't want any kind of bias going into the exam. So I got to meet the patient with fresh eyes and no preconceived notions of what I might find.
So, with this patient, was she expecting, did she have an idea that the pelvic floor could be involved? Or was this a surprise to her when she got to see you, Dr. Edgar?
All of the patients that we were going to be treating in this research study were informed of the role of pelvic health and pelvic floor. If Jasmine was meeting them for the first time, which was the case, I think 100% of the patients, she explained the pelvic floor muscles can often be a culprit for contributing to hip pain, SI pain, low back pain. So I have this coworker and we're doing this research study. Are you interested in being a part of it? So everyone had informed consent going in. And so when I met this patient, I then re-explained the role of the pelvic floor, why it's important to look at, and how it might be contributing to her pain. So it wasn't a surprise, or at least it was less of a surprise after Jasmine had met them first, and then I got to re-explain things the second time.
That's a great explanation. I know one of the challenges is if somebody enters a clinic thinking that it's totally orthopedics, and while I'm a believer that the pelvic floor muscles are just like other muscles of the body, if we transfer to pelvic health, that they can be a little surprised, but it sounds like you did a good job transitioning there. And each person in their clinic, if they're not doing a research study, may have a different transition way they do it, but it's got to be done well. And it sounds like you both did a great job with that.
Yeah, and I think I'm always surprised when I meet a patient who comes in for pelvic floor physical therapy and are then surprised that I have to assess their pelvic floor. So getting all of that informed consent is paramount, and hopefully makes things less surprising as patients come in.
Yeah, I know in my own practice, if they are referred for pelvic health, they're not as surprised. But if they're referred for something they didn't think had to do with pelvic health, it's a more detailed conversation. And depending on
Yeah.
who it is, depends on how that goes. And obviously, we never do anything that patients aren't comfortable with. We need to make sure we explain, the benefits of what a further examination could provide.
Absolutely.
So Dr. Green found positive Laslet cluster, said it was it's SI joint pain. What were the findings in the examination that you had, Dr. Edgar?
So my findings for this patient were high tone pelvic floor muscles. So she had both in for the exam that I performed, and then also in a later session when I did surface electromyography, she presented with high tone, meaning her pelvic floor muscles were holding just a little bit more tension than is functional. So she was unable to achieve a full range of motion of her pelvic floor. She also had tenderness both at the introitus, so like the closer to the vaginal opening, as well as in the deeper pelvic floor muscles. She explained to me that she was having some pain with intercourse with her partner. So this was not surprising that I found pain deeper within. And then that information informed my treatment further on, which was largely down training her pelvic floor muscles and helping her in achieving a full range of motion of her pelvic floor.
Very good. So to summarize, Dr. Green found SI joint pain, primarily using Laslet cluster. And then Dr. Edgar, pelvic health therapist, found higher tone pelvic floor muscles that correlated with some of the subjective complaints she'd had.
Yeah. And then, Jasmine, do you want to speak a little bit to her muscular kind of like strength deficits that you found?
Yeah, I was going to expand on that a little bit because personally, as a clinician, I'm less inclined to box someone in based off the diagnosis of SI joint pain. And I more care about what impairments that the patient has. So while I did confirm that she had SI joint pain based off the Laslet's cluster and the location of her pain, she was pointing directly on top of her PSIS. I more so cared about the fact that when I watched her gait, she had a significant Trendelenburg gait. And then when I tested her strength and I used a handheld dynamometer, she had significant hip weakness kind of globally across both sides of her hip. And then as well as she also had a lot of tightness really going on more so in the anterior aspects of her hip, so as iliacus, quads, and things like that. So those were the kind of like bigger impairment based things that I noted on her initial eval, that then I focused on those impairments that I saw on the initial eval to then give her her home exercise program on that first day. So it's less of the fact that she had been diagnosed with SI joint pain and more based off the impairments that I saw.
For this patient, that sounds like an excellent approach. Can you, Dr. Green, describe a little bit more about the exercise you gave her first day and the interventions that you provided her?
Yeah, so the exercises that I gave her on the first day were Froggers. So think like a child's pose, but your hips are in a internally rotated position. So you're getting a hip stretch at the same time that you're kind of working on your low back mobility. I gave her a posterior pelvic tilt with a bent knee fallout. So trying to start to engage some transverse abdominis at the same time doing a little bit of higher level core control with a bent knee fallout that was added on top of that. And then I gave her bird dog, but she was doing arms only. So traditionally that bird dog is opposite arm, opposite leg, but it was too hard for her on day one to control the lumbopelvic hip complex. So we just started with arms only. And then I attempted to give her a cat-cow, but dropping down into that kind of thoracic and lumbar extension was irritating to her SI joint. So I nixed that one on day one and just left it with the Froggers posterior pelvic tilt with bent knee fallout, and bird dog's arms only.
Excellent. Dr. Edgar, could you expand a little bit on treatment that you provided? You hit a little bit of it earlier with down training. Can you explain for our listeners what is involved in down training and anything else that you did with this patient?
Yeah, so when I am approaching a high tone pelvic floor, I offer a lot of patient education. On day one with this patient, she had mentioned she was having pain with intercourse. So I talked about basically having pain when you have sex is going to increase your pelvic floor's tension because it sort of goes on defense. So I talked a lot about making sure that she is avoiding the painful moments in intercourse, and so that we could progress together and get her to the point where she was pain free. Furthermore, when it comes to down training, breath work is a huge part of that. The diaphragm and the pelvic floor have a piston like relationship. In other words, they move together. And when you take a nice deep breath in, diaphragm descends and the pelvic floor then lengthens. So using nice deep diaphragm breathing was one of the things that I offered her day one, in addition to kind of the education regarding avoiding painful sex. Furthermore, I love having surface EMG in my clinic. It is one of my favorite tools to use for down training because the patient can actually see on the screen what it looks like to maybe contract their pelvic floor and then relax. And then they get to see that they're kind of resting at this higher level. So I use visualization, breath work, and mindfulness to assist the patient into reducing tone. I'll also use different positions on EMG to show the patient where they might have higher tone, and this can relate to things like toileting or intercourse positions. Another interesting finding for her was her coccyx was not neutrally aligned. It was a little bit deviated and a little bit flexed. And why this matters is because a high tone pelvic floor can almost pull the tailbone inward and maybe change the neutrality of it. If one side of the pelvic floor is a little bit more tense, the coccyx will tend to deviate towards that side. So in addition to down training the pelvic floor and doing breath work, I also did some manual techniques for her tailbone. And she had benefit from this, both in pain relief, and then it also helped improve her innominate asymmetries. So Jasmine and I both found that her innominates were not symmetrical. And what was interesting about this is some days it was a right anterior innominate and other days it was left. And I found that after I started with the tailbone, she started to just carry a little bit more symmetry in the innominates visit to visit. So that was another approach that I took to addressing her SI pain in addition to her pelvic floor.
I'd like to echo or reemphasize something you hit early on there, because there's some things there that maybe our orthopedic, primarily orthopedic physical therapist listeners may not be able to do or may not be comfortable with, but breathing with coordinated pelvic floor movements is something that I think that we can all do. And I find a lot of bang for my buck with that. And anytime we are thinking about our breathing, there's more mindfulness in that as well. So there's a big bang for our buck for all of our listeners. Dr. Green, you had noted that you did dry needling in this case, but there was increased pain, and then you chose not to do it again. Can you tell me or tell us where the dry needling was performed anatomically?
Yeah, so I did her dry needling in her lumbar spine, and I did levels L4 and L5 for her. And she felt mild, like your normal mild uncomfortability with the needles in during the dry needling, but no adverse reactions while the needles were actually in. Then when she came back the next session that I saw her, she was like, whew, like those needles felt awful. Do not want those again. And so I'm thinking, like, why did she have such a poor response? Like I really was thinking that she would come back to be like, oh my gosh, my back feels so much better after those needles. And then I started talking with her again and remembered she had a really bad experience when she got her epidural during her childbirth process. And so I when we were talking through me explaining what dry needling was, getting that informed consent from her that it was okay to do, she was like a little bit nervous about just like having needles again. And so I think she had such a poor response to specifically dry needling as a modality because just needles in general, she was equating back to a poor experience that she had with her epidural. And so even though those are two totally different techniques with needles, I think sometimes if patients have a phobia or they just have kind of like a negative mindset with needles, you can get some poor outcomes from the dry needling. And so I think that's why she had that reaction, one. And then two, that's why I chose not to do that again with her. I was like, I have other tools in my tool belt to get her muscles to relax, to get this reset that I'm needing for her sympathetic system. So I chose to go with those other tools versus trying to continue needling with her.
That's great reflection. Sounds like that with a similar patient, that dry needling may be on the table for you again. But when you thought specifically about her previous experience with another type of needle, that's likely why this patient didn't respond as well. That's great reflection.
Yes, I have so many patients that benefit from dry needling. I do it every day in my clinic, usually most of the time at the University of Arizona as well. So there's definitely a lot of benefit from doing dry needling, but I do think you have to take into account those people that are needle phobic, those people that have had poor experiences with dry needling in the past or poor experiences with something like acupuncture that is similar, but the methodology is different. And so all of those things together can cause your patient to have some poor reactions. So not saying that if your patient has those things to not do dry needling, but that's definitely something that I've started taking more into account and really deciding like, okay, is this something that I truly think is beneficial for them, or can I do the same thing, but in a different method?
Reflective practice is how we grow, and sounds like you're doing that very well. Sticking with Dr. Green on this one, while disability improved according to the Oswestry Disability Index, the patient still had a ODI score of 24%, which is typically considered moderate disability. You recommended continuation of the plan of care, it noted in the poster presentation. Can you share your thoughts of what occurred here with the somewhat decreased disability and then, but not enough, and then the recommendation of the continuation of plan of care?
Yes. So when we reevaluated everything, so her Oswestry index, her handheld dynamometer hip strength, everything that I looked at and tested on the initial evaluation, it was actually done at 6 weeks of her plan of care, not 8 weeks. And that was just due to some time constraints, general life habits, and things that just popped up. So I was like, I really just want to make sure that we have this information and I don't want it to go past the 8 weeks. So we decided to do it at 6 weeks instead. I think Minija actually tested some stuff a little bit later than me, but for all the stuff that I looked at, it was actually at 6 weeks. So that's why I think you're finding that she had that improved back pain, but the ODI wasn't all the way down to that 0% mark yet. I also think that's why we found that her strength either stayed the same or decreased, because we weren't at that 8 week mark that you're going to start seeing the true strength gains, as well as the fact that Minnie and I both had focused more on neuromuscular reeducation versus specifically strength training and where she was at. So there was functionally some things that she still wanted to improve upon, which is what reflected in her ODI. And so that's why I recommended her to continue coming to see both Minnie and I, and we could start to shift her plan of care at that time to focus more on strengthening. Now that we had calmed her pain down, now that her anominats were looking more aligned every time that she came in to see us. And so now we could focus more on, okay, you're trying to get back into working out. Okay, let's start upping up your strength program on this nice progression here and see how you do.
I definitely understand wanting to get data in early if you're afraid that you won't get it later, especially when you'd had trouble having other subjects being able to hit the whole thing, especially with a, somewhat longer 8-week plan of care.
Yes, it was honestly wild because it was just like a little texting back and forth, like, hey, can you please actually come in on this day? I really need to get your data in. You're the only one that's been super consistent so far. And she was like, of course, like I'll come in whatever time that you need. We'll make it happen for you. So I'm very thankful to have had her as one of our patients in the overall research study, and especially to be able to do the case study on her.
And did she continue with plan of care after that? Did she go with the recommendation, or did the other life issues, did they prevent her from continuing?
She did continue for a little bit. It wasn't the full plan of care that Minnie and I had written out for her, but her partner is also a strength and conditioning coach that I personally know. So money-wise and having access to a strength and conditioning coach as your partner is fair. I think she actually continued seeing Minija longer than she continued seeing me at that point too. I can't remember, Minnie. Do you?
I looked back at that this morning, and you guys saw each other a couple more times near the end there. But towards the end, her and I were coming back to really addressing the painful intercourse because that was important to her and her quality of life. So we worked her a couple more visits to specifically address that. And then you saw her a couple more times to kind of put a bow on everything. And she discharged to a home program with what we'd given her, and then with her partner assisting and returning to some strength gains.
Very good. As we're wrapping up this case now, first to Dr. Edgar. When I reflect on patient cases, I identify things I would often, I would have done differently. If I saw that same patient in the future, sometimes I would do an intervention earlier. Sometimes I realized that an intervention I did maybe wasn't necessary. Sometimes there are interventions I didn't do, but I wish I would have. As you've reflected on this case, what would you change?
I feel like almost a completely different clinician now compared to when I first saw this patient. We first met about a little less than a year ago at this point, and I was less than a year into my residency program, so very fresh new grad. And I think that my skills and my knowledge of treating SI pain has grown exponentially since that time. So there are a lot of things that I didn't even know to look at. Things like motor planning and muscle activation, for example, with hip extension. It's been shown in the research that people with SI pain initiate hamstrings and they biceps femoris over the glutes. And so the glutes become weak and the biceps kind of hypertrophy, but still might be on the weak side and just really tight. So I didn't even think to look at that because I was unaware of this research. So that's something that I would have looked at and maybe started doing some neuro re-ed in terms of motor planning. Additionally, I recently was studying for the women's health specialty certification exam. And there was so much research that I consumed on treating SI pain from the pelvic floor perspective, especially postpartum. So what I would love is just to take a fresh look at this patient 1 year later with the new information that I have, the experience that I've gained over the past year. I also wish that there was a little bit more wiggle room with her in terms of trying dry needling. I have had excellent results with dry needling, the SI joint specifically. And if she was more open to dry needling, I would have loved to stick a couple needles in the joint and see if she had improvement with that a little bit quicker.
I think it's hard, Minnie, because listening to your reflection, I think we probably could have gone more with the dry needling. And I'm thinking about how I educate my patients on dry needling now versus how I educated her back then. And just because I've used it so more, it's been 2 years now since we've been dry needling certified. So I think we would have had more wiggle room had if we had been at this time and met her right now, and our explanation of hey, this is what you should expect. It's not going to feel 100% comfortable, but this is the bang for your buck that you're going to get. I feel like we would have had a little bit more wiggle room. And I feel like the place that I would have gone with my needles would have been a little bit different to target more of her sacrum and more of the actual SI joint versus trying to attack her lumbar spine first.
I appreciate both of your candid responses. Well, I think we've had a great discussion on combined orthopedic and pelvic health approach. If the only thing our listeners take from this podcast is reflective practice and changing based on that reflection, it'll be a worthwhile podcast. I'll also echo what both of you identified as maybe needling the SI joint. I found that maybe that's near the top of my most powerful areas to needle and where I get responses with that are difficult with other interventions. When you get right down in that ligament, there at the SI joint, I find excellent responses there, as it sounds like you've had with other patients and you wish you could have done with this patient.
Yeah, definitely. I also think when it came to co-treating this patient, as we were trying to figure out exactly how this was going to work from a research perspective, I think we sort of were running into barriers in terms of like, what do we want out of the ortho side of this and what do we want out of the pelvic floor side of this? And I think now, again, like a year later, I am much more holistic in my full body approach than I might have been early on in my residency. So I take orthopedic approaches and apply them to my pelvic health patients. And so when we were working with this patient, it was like, okay, what is within the box that Jasmine is working in and what is within the box that Minija is working in, when really it should have been more of a Venn diagram. And I think that we did our best to offer the patient excellent plan of care with excellent treatment options. But as I reflect on this, I think it would have been better for the patient specifically if that looked more like a Venn diagram. But when it came to the research side of this and figuring out how we wanted to present our findings, I sort of felt like we were almost limited in that way. I don't know, Jasmine, if you agree with that. Do you have any thoughts on that reflection?
Oh, yeah, I definitely agree with that. It was like, okay, here's what I'm going to do in my ortho world, and I'm going to let Minnie tackle all of the pelvic health things, and I'm not going to address any of that in my ortho sessions because Minnie is already tackling that in the pelvic health sessions. But now, like as we're going into prepping for another research study that we're going to do with a similar background and focus, I'm like, we can totally overlap into each other's sectors, and that is actually what makes them better. But even like reflecting on our case study, and even though we have all these things that we would change, I still go back to the fact that this patient was one of the first patients that I saw with SI joint pain that got better so fast. Like, I think it was week 3 or 4 that she was like, oh my gosh, my back feels so much better. And I can do this with my kid now that I wasn't able to do before. And I really want to start trying to work out soon. When do you think I can start working out? And so seeing the success that Minnie and I had with this patient has just fueled me to make sure that I am screening for pelvic floor dysfunction anytime I have a patient that comes into the clinic or at UA that is being seen for low back pain, they're being seen for SI joint pain, they're being seen for hip pain. I am always now screening for any pelvic health dysfunction. And as soon as you're popping up with even just one of the potential flags that I have for potential pelvic health dysfunction, I say, hey, this is your pelvic floor. This is what it does. This is how it could potentially contribute to your associated pain. I just want you to get a consult with one of our pelvic health therapists. They're just going to talk to you about how this might be affecting you. They're going to do a more in-depth examination than what I just discussed with you. And then it could potentially look like, hey, you just need to see me still, but I'm going to add X, Y, and Z in for your pelvic floor. Or it could look like what Minnie and I have done, which is you see me one time a week, and then you see the pelvic health therapist one time a week, and we're co-treating you together. Or it could be like, whoa, slow down. There's actually too much pelvic health dysfunction right now for you to even be able to see me. So you're actually going to hang out with a pelvic health therapist until you're ready to co-treat or until you're all the way better. And then you can come back and see me and we'll clean up the orthopedic dysfunction and then send you on your way. And so I think that is like the diamond in the rough and the gem that Minnie and I have found doing this case study. And I'm so glad that we did it.
Well, Dr. Green, I'll speak for all pelvic health therapists and say that we're very happy that you realize the importance of screening for, pelvic health issues, pelvic floor specifically, with people with low back pain, hip pain, pelvic girdle pain.
Yes, it's amazing. Everyone should do it.
Dr. Edgar, anything final you'd like to add on this case, building off of Dr. Green's comments there?
No, I think she really hit the nail on the head. If anything, I'll just say stay curious as a pelvic health PT or ortho and stay open-minded. Never get to the point where you're giving all your patients the same 3 exercises. They deserve so much better than that. And it's important to treat them like a whole person, not just their dysfunction.
I will give an amen to that. Moving on from this specific case, I'd like to any of your thoughts or reflections on going to CSM and doing a poster presentation. Some of our listeners have done posters and even presented at conferences, and some haven't. Anything that either of you would like to share on your experiences with that?
I can start. That was my CSM 2024 was my second CSM, and the ability to share something that I was excited about and had put a lot of time and effort into with one of my friends and colleagues made the experience so much more fulfilling. And I was so much more interested in the other research everyone else had done because I knew how much effort and time and consideration goes into it. So it definitely improved my experience and made me excited for CSM 2025.
So that was actually my second time doing a poster at CSM. It was my third overall CSM. I had done a poster the previous year as a student while I was in PT school. And then this was my first time being an actual doctor and then getting to do it with a colleague. So it was a very interesting flip-flop because I felt more prepared to give the poster presentation, but at the same time, more so nervous because it wasn't going to be me and my professor standing by the poster answering everyone's question. It was, all of the heat is now on me and my coworker. So that was a very interesting caveat, but overall, it's such a fun experience to be able to present a poster. And I'd really like for Minija and I to be able to level up now and try and get a platform within the near future with more of the research that we're trying to do, because I just love for more of this information to get out there, especially for a lot of the female athletes that I work with. So I think this is it was a nice starting point for us for sure.
And how were the questions? Did people have pretty tough questions for you? Were you comfortable answering them?
I think we did a pretty good job of answering the questions. Some people asked more basic questions about just how the heck we did a clinic-based research project. We had a few people ask more on the nitty-gritty of why we did things that we did and what we thought of our results and whatnot. But I think between the two of us, Jasmine and I felt comfortable with everything we got asked.
That's excellent to hear. How was your process in developing the poster with getting the template, making it look visually appealing?
I'm laughing because the actual process of putting together the poster was super easy. Our company, because so many people have presented at CSM previously throughout our residency program, that they just have a template and we kind of just type all our things into that template. Melissa Buss, our residency coordinator, prints it out for us. And I was giggling at the beginning because we had a fiasco. I was in charge of the poster and we were checking in for our flight. And I left the poster at the ticket counter. So I was sprinting through the airport trying to get the poster about 5 minutes before we were about to start boarding. And it was locked up in some room that I couldn't get back. So we actually had to reprint our poster when we got to Boston. So the creating the poster was the least of our problems.
Well, glad to know that there's now 2 printed versions of this poster.
Yes.
And I think it also highlights something that I wanted to emphasize. I didn't know what the process was for either of you, But if you can build off of a template that somebody else has used and use somebody who's experienced with this, it goes a long way. I know on my first poster, I collaborated with Jody Young, and we used a template that she'd used before and were able to just insert, the information for the current case. But if you're doing this for the first time and you want to be able to collaborate with somebody or use a template from somebody, get a little bit of guidance so you're not just trying to recreate all that on your own. Well, very good. Well, that wraps up the podcast interview. I appreciate both of you, Dr. Edgar and Dr. Green, for your candid comments, your very thoughtful reflection, and I hope that our listeners appreciate this as much as I do.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.